Oh, yes, the recording. We will be recording a session as we usually do with our WebEx webinars, and we post them on our social media platforms and YouTube later on for anyone who likes to watch them again. So in today's Kawakeb webinar, we have Dr. Thalia Arawi, who will be presenting on deconstructing the difficult patient, the case of the elderly. So Dr. Arawi is the founding director of the Talim al-Hus Bioethics and Professionalism Program at AUBMC, which is also the first WHO collaborating center on ethics in the Arab world. She's also a clinical bioethicist and clinical ethics consultant. So without further ado, Dr. Arawi, thank you for giving this session today, and we look forward to a very fruitful discussion, hopefully.
Good evening, everyone, and thank you very much, Diana, for your introduction. Is this clear? My voice is coming through well?
Yes, very clear.
Okay. So today's talk, as noted by Diana, is deconstructing the difficult patient with an emphasis on the word difficult. And I'm taking the special case of the elderly as an example. So first of all, I'd like to declare that I have no conflict of interest whatsoever presenting or giving this talk. And the objective of today's talk are the following. A brief look of what aging is, what is the difficult patient, the characteristic of a difficult patient, the idea of deconstruction and deconstructing the difficult patient factors, physician's factors, system factors, reconstructing the fractured physician-patient relationships, and perhaps some tips on dealing with a difficult patient. Just a quick comment. This presentation is very brief in the sense that there's a lot more to say, but I have to limit my presentation for the sake of time. So I thought the best way to define aging is a quote from Simone de Beauvoir, the French existentialist. I quote, "Old age is a problem on which all of the failures of society converge, and that is why it is so carefully hidden." I think this statement from Simone de Beauvoir in The Coming of Age says a lot about aging, particularly in this part of the world, which is the Middle East, since we still have to some extent a bleak, if you want, vision of what it means to be an elderly. This is Simone de Beauvoir in her childhood, just to show you how time impacts, I dare to say, the lucky ones, those who are given days and years of their life to grow old. So the literature summarizes the different types of difficult patients with these adjectives: non-compliant, overly demanding, overly talkative, angry, insulting, and I'm sure many of you in your experience have faced something similar to that, or can add at least one other adjective. A physician's survey explaining or asking physicians to explain what they think a difficult patient is noted the following: they are non-adhering, they don't adhere to our orders or our medical treatment plans, they are too demanding, they're verbose and they lack focus, they have multiple medical complaints, they often suffer from chronic pain, they are often drug seeking, of course, among others, but these were the main highlights. Now, here as clinicians and ethicists, we all want the same thing. We all want to help our patients heal. We all want to keep them healthy as much as possible and whenever possible. We all want to make them happy as much as possible and wherever possible, to fulfill ourselves, to manage our time, to make a living, of course, and to meet our professional expectations. Sigmund Freud dealt with a number of so-called difficult patients, and referring to a patient who suffered psychosis in his letter to his friend Istvan Holos in 1928, he says, "I do not like those patients. They made me angry, and I found myself irritated to experience them, as they seemed so distant from myself and from all that is human. This is an astonishing intolerance which brands me a poor psychiatrist." And I think if we were to reflect back on what we go through when we deal with elderly patients in particular, or with any kind of what we label as difficult patient in general, if we were to allow ourselves the time to examine our lives as Socrates would have it, we would feel that we are willing to say the same thing, an astonishing intolerance which brands us as poor clinicians, because something must have been missing. So the literature again characterizes difficult patients as exhibiting fear, hatred, inaptness, dissatisfaction, helplessness, hopelessness, and worthlessness. As far as boundary is concerned, they are disrespectful, they blame us, they complain, they are non-adherent to treatment, they threaten at times, they are demeaning, they manipulate us, they are seductive, litigious, dependent, obsessive, mistrustful. Of course, not all these need to happen or to exist at the same time. It suffices to say that some of these characteristics are present to quote unquote label a patient as a difficult patient. Circumstances complicated by homelessness, loneliness, death and dying, financial problems, legal problems, religious and spiritual issues, and cultural issues. These are factors that complicate what it means to be a difficult patient, if you wish. And of course, it's difficult to diagnose illnesses in this case, because there's often a history of mental illnesses, or so they say, substance use, personality disorder, chronic medical condition, pain, disability, obesity, sexually transmitted infection, terminal illness, medically unexplained illness, malingering, fat folder syndrome, and others. So let me present a case here. This is Nuran. Nuran is an 82 years old senior citizen admitted for UTI and dehydration. We requested blood withdrawals, and we discovered muscle atrophy due to an early discharge from the ICU, during which he stayed for more than 2 weeks. When he was readmitted, Nuran kept on refusing any statement that says we need to draw blood. So blood withdrawal was out of the question. Even when we assured him that we have excellent phlebotomist, he kept on refusing. He screams whenever there's a mention of a possibility of inserting a Foley. And he tells nurses to leave the room whenever they come, angry, and shouts at them. He wants to walk and leave, but when the team comes to help him walk, he refuses to move and says that he is tired. So you can sense there's some contradiction, something is wrong, but this is a typical patient who is often labeled as a difficult patient. So the healthcare team, as a result, are irritated. They feel insulted, and rightly so. They are in a vicious circle because they want to do something, they want to help, but they find themselves in a catch-22 situation, if you want, a weak loop, a no-exit situation. One of the most important things that is important for us to keep in mind when we deal with elderly is that hospitals induce some form of mental turbulence with them. Frequent UTIs also mean mental fog. And there is a syndrome that exists whenever an elderly enters a patient, more so than not. They develop some form of psychosis merely because they are in the confines of a hospital. So Nuran is difficult, we are irritated, we are angry, but there are a few things we never knew about Nuran. And had we known them, perhaps we would have understood why is it that he's so angry, why is it that he's so demanding. First of all, he had a previous fall when nurses tried moving him. So he was afraid of trusting patients to move him around. And he comes from a dignified family, self-reliant, does not like to impose on others. He has always been independent, with a sense of pride, and cares a lot about his privacy. He is psychologically troubled. He has 1 in 100 thing on his mind, as probably all of us do. And most importantly, Nuran is tired from being sick. I will take you back to Simone de Beauvoir when she talked about the philosopher whom she befriended for quite all their lifetime, perhaps, Jean-Paul Sartre. She speaks about his health and she says he has diabetes, slight strokes, dizziness, teeth problems, incontinence, and worst of all, near blindness. And then she quotes him saying, "He looked at me with a look of anxiety and almost of shame. Shall I never get my eyes back?" There are troubles that often the elderly do not share with us. They might share with someone with whom they have built a strong bond of trust. And this lingering fear in their unconscious, preconscious, or even their conscious affects the way they interact. Now, there are also clinician factors that exacerbate the situation. It's not only the background from which the patient actually comes. So as clinicians, it is important for us to recognize our own trigger issues and to know what personal baggage we bring into the patient encounter, for this can be extremely valuable. We need to diplomatically bow out of commitments, delegate to others as appropriate, and seek work environments that value setting appropriate limits. When a physician is burdened, burnt out, overwhelmed, distressed, he can say or she can say, "I cannot handle this elderly patient at this time," or whatever patient at this time. We also need to identify trigger issues and avoid situations in which personal beliefs may inappropriately close off adequate exchange of information and the shared decision-making that is so critical to a healthy patient-physician relationship. We tend to assume that the elderly are demented. We tend to assume that senior citizens will not be able to comprehend. We tend to assume that senior citizens require a proxy decision maker or someone to make decisions on their behalf. But the fact is, at least 80% of the time, senior citizens are competent, capacitated, autonomous, and are capable of making these decisions. The mere fact of talking to their siblings instead of them leads them to a form of downshifting, to anxiety, and withdrawal, because we have one way or another unintentionally attacked their dignity. So system factors. System factors can include how busy we are as clinicians. It can include bad experiences with prior withdrawal of blood, inexperienced phlebotomist, or very experienced phlebotomist, but not specialized with geriatrics, who often have very, very thin vein and low tolerance level. System factors include when we are busy with something else, which unfortunately happens quite a lot. System factors include things that we use at the hospital without paying attention that affect the dignity of patients. The simple example is the hospital gown that oftentimes destroys the privacy of the patient, because the mere fact that a patient is wearing that gown immediately renders him or her fragile. And of course, needless to say, physicians who are not willing to communicate and to spend enough time with the patient. So it is important to inform the patient of our plans. But most importantly, we do this sometimes, yet we never stick to the promised plan. So that's another thing that we need to avoid. Now, it's also extremely important to understand that communication is key. So what do you think is going on is important. We need to validate their concerns as legitimate and empathize with them, even though we might think that their worries or concerns are not legitimate. For them, it is legitimate, and we have to understand this and appreciate this. And repeat, let me make sure that I heard you right. Let's agree on what we can accomplish in this visit. We are in this together. And most importantly, again, it is important to realize that most patients, particularly senior physicians, senior citizens, have hearing problems. So at times, they don't really hear what you're saying. Some are, they can ask you another time, but the third time they might feel ashamed. They will not ask you. And this is something that you need to decipher using your own cues. Physical posture is extremely important. Non-verbal communication, which already tells the elderly or senior patient you are important or not important. And of course, tone of voice. We definitely need to have a different tone of voice whenever we're talking to senior citizens. One thing we do out of care and innocence, perhaps, is we baby senior citizens, which actually is a very big mistake, because they are very well aware of what's happening to them, and it touches on their dignity as well. So posture is important. Sometimes silence says a lot. Our attire, body expression, all this helps affect the way the patient reacts to us. And this is an example that happened once at the hospital. There was a troubled patient who was unable to make decisions in connection to his care. He was scheduled for a serious surgery, a major surgery, and then started having doubts, particularly when different physicians came and visit him to tell him whether this surgery will be easy on his, let's say, kidney, on his heart, on his whatever. So looking at the patient not as one whole being, rather as a sum of organs. What is fascinating about the story I want to share you is that it took only one physician, a simple gesture and a smile, to make that patient feel at ease, and for him to decide that he is okay going with the procedure. And that is when the surgeon came and saw him, kneeled and sat at his level, patted his shoulder, smiled at him, and told him he trusts him and he can make it. So this humane, if you wish, gesture is oftentimes what patient needs. Another important tool that we tend to ignore is reading facial expressions, which can save the day. For example, you can look at the eyes. First picture, it shows you sadness. I'm going to let you think about the second picture and then give you an answer. So there you go: anger, contempt, disgust, surprise, and fear. They might not voice it, but you can see it in their eyes or in their facial expressions. Another thing that we often tend to forget when it comes to elderly is that coming with masks, suits, them not seeing our faces is often source of anxiety and fear. This is why in different hospitals, they are now doing their best to show their faces to patients, and this is to comfort them. Which brings me to a question that I will not address. What will happen when we start using humanoids instead of nurses, or instead of visiting physicians? That's a totally different story. One thing that is also important is we often respect, or we always actually respect our patients, but the elderly, they tend to tell them, we call them teta, i.e. grandma, or Mrs. We never use the first name, but the first name is the most important thing and the sweetest language for a patient to hear, because there's something magical about first names, using the first names. Now, why is it important to deconstruct all this? Jacques Derrida, who is known as the father of this philosophy, He says that dismantling our excessive loyalty to an idea and learning to see the aspect of the truth that might lie buried in its opposite is deconstruction. And by this, I'm referring to our labeling and our judging that patient as being difficult. We need to actually dissect it and to see what actually is buried in that term and its opposite. We need a kaleidoscopic view of reality. We need to be aware of an impasse or puzzlement, which is a state that we should constantly visit shamelessly. It is not an evidence of the adulthood. It is actually doing that is an evidence of the adulthood of the mind. There are multiple factors deconstruction teaches us that contribute to producing the experience of aging, because it is an experience, it's not a state. And aging in and by itself is not an illness. So we don't cure aging. So the factors include economic factors, biological factors, social, statistical, historical, cultural, and sometimes gender and personal temperament. A person, Michael Lurie, spoke of growing old as a kind of asphyxia in which one moves from boundless to the bounded. Again, I go back to Simone de Beauvoir and The Coming of Age, in which she says, since it is the other within us who is old, it is natural that the revelation of our age should come to us from outside, from others. We do not accept it willingly. So as you can see, she is saying it is the other within us who is old. I learned years and years ago, and I was not aware of that when I was participating in a workshop, that elderly patients are old only in their bodies. They are still joyful and young as far as their souls and minds are concerned. And this is something we tend to forget. I personally never knew it until I learned it from that workshop. So it's an other within us who is old. Society, she says, turn away from the aged workers as though he belonged to another species. That is why the whole question is buried in a conspiracy of silence. Old age exposes the failure of our entire civilization. And this is something we often forget to teach our students, is that this is part of the social determinants of health. This is part of the social determinants of sickness in the elderly. There's only one solution if old age is not to be an absurd parody, she says, of our former life, and that is to go on pursuing ends that give our existence a meaning. And that is something that we really need to help our patients to actually develop. And finally, she says, at some point, old age was growing inside me. It kept catching my eye from the depths of the mirror. I was paralyzed sometimes as I saw it making its way toward me so steadily when nothing inside me was ready for it. Even simple tasks, now this is about, Simone de Beauvoir wrote this, okay, so a while, years ago, and then she became a senior citizen, and someone wrote her biography, and this person, who was her friend, says, even simple tasks such as walking the few steps from her sofa to the refrigerator were agony for her. Horrified guests sat glued to their chairs, wondering whether to get up and help her or pretend that nothing was amiss. She behaved, however, as if nothing were wrong and insisting on following her usual routine. So there's a lot that goes on inside the young mind of an elderly patient. And again, this is a very important and strong quote in which he says, since it is the other within us who is old, it is natural that the revelation of our age should come to us from outside, from others. We do not accept it willingly. So my question at this point is, are we actually all potentially difficult patients? A patient might not be aware of your being there to help them. You think, why are they turning their back? Why can't they listen to my orders? And then you realize they are already somewhere else. Same thing for this senior citizen who was a previous scientist. So these are things we never think about. And at this point, I'd like to refer to two concepts, if you wish, phenomenology and moral imagination. Phenomenology is the only way a person appreciates his or her old age, by removing the accidental characteristics around this person. And for us, we need to remove the accidental characteristics in order to understand what that person is going through. Moral imagination is the only way we can actually understand old age. This insane woman, according to some, particularly in certain areas of the world, they look at her, they make fun of her, but the truth is something we don't see, but she sees, which affects her psyche more than we can imagine. And narrative matters. We, as clinicians, we tend to be in a hurry. We tend to be edgy and don't have time to listen to the lingering stories of elderly patients, sometimes repeating themselves. So this person here, he taught philosophy at the University of California for 40 years and wrote a number of books. And he himself, Herbert, says, I can do a lot of usual things of life, but now they are most of them done with effort and special care. And that's one of the challenges I have had it to come to terms with the need for help. I often walk around the house and I ask myself, often out loud, what is the point of it all? These are things we never think of when we're dealing with what we call a difficult patient. Now, as you can see, these are identical floors in a way, but they are similar in the sense that one is filled with flowers and greeneries, the other one is blocked, there's nothing on it. The idea is we tend to judge, we tend to label, but no two people are alike, just like these two balconies. And most importantly, while we agree that everyone is fighting a certain battle, including ourselves, their battle is often more hidden than we can imagine. We see the appearances and they look fancy and stunning and meticulous, but what lies behind is often complicated, painful, and not easy to understand. And this applies to us as well, of course, but we have a moral obligation, I guess, to forget about our own worries whenever we are on the call, in the call of duty, as we say. So to conclude, I would like to say that there is no such thing as a difficult patient. Using the term difficult patient is labeling in and by itself. It is judgmental in and by itself. And the mere fact of using it and teaching it to our students make us treat the patients in a way that we should not be treating them, that makes them appear, quote unquote, more difficult than we think they are. Rather, instead of saying a difficult patient, let's start using the word the encumbered patient. There are no difficult patients, there are only encumbered ones. As the saying goes, ورا كل بردية حكاية. And behind each curtain lies a story. Thank you very much, and I'm happy to answer your queries.
Thank you very much, Doctor. If anyone wants to ask a question, you can go ahead and unmute yourself or write in the chat if you prefer that, and we will read out your question.
I have a little one. The issues you identify in the elderly or the more senior patients sometimes also exist in younger patients. So what is the approach? Do you use different approaches for when they are young compared to when they are elderly, yet they display the same manifestations in terms of behavior and distrust and all of that?
So thank you, Dr. Lahir. Indeed, as noted earlier, and this is a very important question, yes, everyone can be labeled a difficult patient. Little children who have the white coat syndrome are often labeled difficult patients. It's perhaps not the same exact technique, but it's generally the same. It's not the same in the sense that children, we talk to them using child language, we baby children. and we need to be patient with them. We don't do that with the elderly, but we need to be patient with them. We need to empathize. Each has his or her own communication requirements, if you wish. In the West, there's a trend now, for example, whenever they want to examine a child, often what they do is they bring a doll, they examine the doll in front of the child, they make him partake with the examination, and then they put the stethoscope on his chest, and the child does not cry. So it is mostly generally different ways to empathize depending on age, but there's also something very important, which is patient-centered care, because every patient is different. There are no totally golden rule. There's no golden rule as such. There are core rules, but there is the periphery that changes depending on each patient. And that's why we speak of patient-centered care, because each patient is unique. And here comes the role of narrative. Us willing to appreciate the narrative of the patient before we encounter and we work with the patient. If you go back to ancient records, for example, of medical notes, and I'm sure you know this much more than I do, during the times of Hippocrates, it was fascinating. The medical notes used to include the attire of the patient, the way he or she walks, where does he live, how far is his house, how many times does he exercise, what are his hobbies. We don't do this anymore. We look at the patient as a case. We forget that there's a big background until, heaven forbid, for everyone, clinicians become patients, and that's when the big wake-up call hits. So that's my rather quick answer.
Thank you, Dr. Thalia. Thank you.
Thank you, Dr. Sharara.
I have a comment rather than a question. The most important thing with the elderly is to gain his confidence. Yani, ideally, one person from the team should be the advocate of the patient. Yani, when I see elderly for the first time, I socialize with him before asking about his illness. Yani, I try to gain his confidence. And even as you said in the conference, even if you don't believe that what he is saying is right, I try to agree with him for some time until I gain his confidence. I remember when I was a fourth-year medical student, one elderly gained my confidence, and I finished my rotation there. I went to another area. They want to put an NG for her. She refused to have the NG except if I myself come and put it. She was so confident in me that
Wow.
whatever I ask her to do, she will. And I think your experience with your late mother is along the same talking. You used to ask me to convince her of doing things. Do you remember?
How can I forget?
Mm-hmm.
So
but the
thank
most
you,
important thing to gain the confidence of the patient. Yani, give him time. Yani, don't treat him as a patient. I treat him as a baby, but not to talk to him as a baby. Yani, to me, all my team, always I tell them I admitted one of my babies, that we have to give him time. We have to agree with him of many things before giving him the right treatment.
Sorry. Dr. Sharara, I cannot thank you enough for this very important issue that you raised. And no wonder you were the first awardee of the Humanism Award. So to refer to what Dr. Sharara is saying, yes, I had this personal experience with Dr. Sharara, with my mom. And even if all of us united were trying to convince her to do an X-ray or to do anything for that matter, she would say no. One call from Dr. Sharara and she would say yes. And the reason behind this is trust and confidence, as he himself said, because patients need to feel they can close their eyes and they are in a safe zone. So shukran, Dr. Sharara.
Thank you, لك دكتورة.
May I comment, please?
Yes, sure.
Swab-
Please go ahead.
Thank you. I'm a dentist, so maybe I'm from a different specialty, and we spend more time with our patients, and we also have this chit-chat social conversation when they come to us, and seeing them frequently makes us always tailor the treatment plans to their needs and demands. We don't see patients as patients or as files, but probably we see them as human beings having, because we have several appointments, they come to us for several times, they have needs, they have demands, they have social occasions, whatever. And I think that if physicians spend more time talking to their patients rather than writing their prescription, they might succeed more in dealing with difficult patients.
Let me say with the encumbered patients. Yes, I agree, Doctor. I agree with you, Dr. Amr. Indeed, in dentistry, and that's another very important issue that you reminded me of. Elderly patients, senior citizens, sometimes need to have fake teeth. Yani they replace their original teeth with, I don't know what you call it, the medical term.
Prosthesis.
Prosthesis, yes, that's it. So we take it for granted, but we never think that to them, this is a blow to their identity, a blow to the way they view themselves. Or so this is another thing that we need to keep in mind when we are treating patients, particularly in hospitals, asking them to remove the prosthesis, mocking if they refuse to. So it all comes with a big psychological package. Shukran, Dr. Shbaita.
You're welcome. And just if you allow me to add that when the patients have their prosthesis, they still feel young because they have a full mouth of artificial teeth, even if they're all artificial, and they will be worrying about their image. Maybe they don't want to remove the prosthesis because they don't want to look old, and they will be worried about how will they eat or how will they talk, and they need a clear speech to talk to others, and this might be why they refuse to remove the prosthesis.
Indeed, so inquiring and understanding and not judging.
Yes, exactly.
Thank you. We have also we have a comment in the comment section from Dr. Ziad Al-Ibrik, who says, based on my experience with the elderly and the ICU, I think the main problem is that we don't include the elderly in the plan of care and have no advanced care planning and advanced directives to give them the time or give them the time to listen to their concerns. So yes, I think
I cannot agree more. Yes, we tend to speak to their siblings. We tend to assume that they cannot make decisions or share decision making. We absolutely.
Doctor, on that point, since it came up with the cases of the elderly and the family interference or involvement, let's say, in the care. Of course, I've heard many stories from you about examples where families because they think they're helping the patient, they want to withhold information. And so, however, sometimes the elderly agree to this. They're not well informed, but they do agree to that they do not want to know more about their condition or their treatment. So is there any, are physicians, do they have any obligation to push further with the elderly patient, or they just from the start they tell them, no, I don't want to know anything, they take their word for it, and they just stick with the family?
Thank you, Diana, for raising this. First of all, legally, from a legal perspective, and also from an ethical perspective, when a patient, elderly or not, says, I don't want to know, I defer everything to X, Y, or Z, forcing information on him or her is a violation of his or her autonomy. So they say no, then we have to respect and say no. But of course, we also have a duty to inquire, even if a little, to understand why is it that they do not want to know. So there, we might help them there, or we might understand that, yes, these persons cannot handle information, they don't want to be involved, they want to ask someone else. They're not pushed, for example, to do so. Now, when it comes to forcing information on them is totally out of the question. And we often get family members who tell us, please don't tell them, they will, I don't know, they will have a breakdown, they will not follow treatment. We have to respect that in the sense that we have to understand where it's coming from, but we also have a moral obligation to assess matters with the patient and see if the patient, him or herself, wants to know everything and to make his or her decisions. We need to convince the family of the importance of doing so. Now, having said that, there are situations when beneficence will trump autonomy, in the sense that telling the patient things might harm that patient. And this is what we call in ethics, as you probably know, the therapeutic privilege. But this already requires that the physician, like Dr. Sharara, مثلا, the physician knows the patient quite well to be able to use the not therapeutic misconception, sorry, I'll come to the غلط term. I'll come to it when it comes to my mind. So it's a privilege that physicians have. Dr. Sharara, for example, knew my mother quite well. He knew what information he can refuse to tell her and what information he has to tell her. And we trusted him. But this presupposes him knowing the patient quite well. And I don't know why the term is not coming to my mind. I'm sure in a split second it will come. Did I answer you, Diana? It's therapeutic privilege. Therapeutic privilege. Okay.
Yeah, thank you very much. Yes, indeed you did. If anyone has any more questions, please go ahead. No?
By the way, most of the cases we face with patients who are senior, not necessarily labeled difficult, is don't tell them we make the decisions. Don't tell them we make the decisions. And there are times, as you know, we discover that patients want to make the decisions and they tell us, please make it a point that my children know I'm the decision maker. And of course, unfortunately, these days, there are situations when decisions are made based on greed. You DNR a family member because you want to inherit. Oftentimes, we catch family members with patients trying and a lawyer making the patient sign for a will or sign for transfer of material, finances, buildings, what have you, and then a DNR is placed. So we have to be quite meticulous about this. It's not always the case, definitely, alhamdulillah, but it exists.
If I may, actually, another question came to mind. Since you're talking about the elderly, and of course, as usual, and this is the issues faced are very culturally specific, and we're used to hear somewhat. We take it for granted that we're very tight-knit society. Families are always beside the next to their elderly. Most of the times, the families are taking care of them. As we just discussed, they're involved in the healthcare. However, what comes to mind now that we're seeing a lot of changes, sociocultural changes. We have a lot of, as you know, the young people, the youth are leaving the country. So there are a lot of family demographic changes that are happening as well. So perhaps this will affect, I mean, in the future, how the care of the elderly that's going to be witnessed in hospitals, because we might have more elderly people coming in alone and not having this family support. So do you think we need more awareness towards this and within the medical education to take into consideration these changes that are happening now, which we will see in a few years, the impact of which we will see in a few years?
Again, a very important question. Yes, so what's happening or beginning to happen now is what is already prevalent in certain countries in the West. I recall when I was rounding in Washington, D.C. in MedStar Hospital, I think all but one of the patients had no one with her. They had no one except one patient. When I asked them about their children, one is in that state, the other one is in another state, the husband has died, and they're alone. So what I'm trying to say is that this change that is happening because of the financial situation or for any other reason will create, as you alluded to, another form of a social determinant of health, because the new health issues are going to arise. New psychological issues, health issues will affect the psychological issues will affect the health issues, and this is definitely something that we need to raise with the medical staff as well as with medical students. And I thank you for bringing this up. It never occurred to us to do that. Usually we complain about the family, not we, many do complain about the family, but the family are the greatest support system, and they are helpers to the physician, because the physician can rely on them to making sure that the patient will take the medication, that the patient is well taken care of instead of not. And they are the caregivers, which makes them also patients.
Indeed. I think we have a lot of changes to to consider in the future.
Yes.
So, yeah.
Yes.
Sorry.
Thank you. Yes, changes, and it doesn't look fantastic, but we have to keep faith, huh?
Of course, definitely. So, I think any last comments from anyone? Okay.
So thank you. Thank you very much for having me,
Thank
and
you.
for everyone who attended.
Yes, thank you, everyone. Hopefully we can continue this the discussion of this topic in future webinars as well, and we hope to see you all soon. Thank you very much.
Thank you.